happening within the ventricles much more often than you will be at the PAC or the PJC level.
Why?
Just simply because we do a lot of damage to our heart, and the ventricles are the largest components of the heart, in particular the left ventricle, makes up about 75% of the heart. So if something is going to be damaged, it's typically going to be in that area. So the atria and the nodal part of the heart, the AV node, typically don't suffer as much from cardiac disease as does the left ventricle.
Okay, is it because the left ventricle is like the most hardest working part of
Yeah.
the heart? Okay.
It's the hardest working part of the heart, and it's the largest.
Okay, that
It's
makes
the
sense.
largest. Like I said, the left ventricle is about 75% of your heart.
Okay.
All
So
right?
wouldn't it be worded trigeminal PVC?
If you were to call that.
Yeah.
So you could call, but I still need the underlying rhythm,
Right.
and I need to know whether they are unifocal or multifocal.
But you could call it normal sinus with unifocal trigeminal PVC.
Yeah, yeah. In however you get it out, I'm okay with that. Okay, so you could say this is ventricular trigeminy with an underlying rhythm of normal sinus rhythm, and then you put in there just simply another line, Matthew. PVCs are unifocal. All right, everybody with me so far?
So putting things like bigeminy and trigeminy takes the place of having to call it a PVC.
No.
You got to specify it's ventricular.
You
Ah,
just-
if you tell me if you tell me it's a ventricular bigeminy, then yes, that identifies it as a PVC.
Okay.
Yep.
Okay.
Yep. Okay. All right. So to Martin, was there a question?
She didn't sign the sign-in sheet, is what she
She's not here then.
said. Oh.
Where's the sign-in sheet? I should have known. Devon's holding it up.
That's right. I hold the hostage, doctor.
Way to go, Devon.
Hostage for my bonus point.
This young lady is getting ready to be counted absent, even though I've talked to her today, all because of you, Devon.
Understood. I'll do better next time.
Okay, here we go. Going, yes,
Me
Elizabeth.
and Piper will need it too.
Pardon?
Me and Piper will need it.
Okay.
Yeah, because I
All right. So Martina asked, what happens if they occur together? Well, basically what we're looking at here is that we have two PVCs that are occurring together. Well, first of all, let's say let's say that this is a for ease, let's just simply call this a 6-second strip. Okay. What's your rate?
the first one or the second?
The top one.
90.
Rhythm.
Regularly irregular? No.
I don't know. I need a
Be
longer
irregular.
strip. I need a longer strip to see if it's better.
Good answer. Yeah, we would have to have a longer strip because we've got these two in here that have jumped
Then
in,
you got 5 beats after.
but we're not sure what's going to be happening on over here. So all we can say is that it's irregular. Okay, P waves.
Absent of the ventricular beats and they're on the normal beats.
Okay, what's your PR interval? Okay,
Normal and absent.
all right. What is your QRS width?
Normal except for the ventricular beats.
Okay, so we would identify this. Just tell me, what would you call this? Before I tell you what the proper name is, how would you describe this to me?
Normal sinus rhythm with PVC.
It's unifocal PVC.
Okay, normal sinus rhythm with unifocal PVCs. What else would you
I don't
want to
know. I
tell
feel like this was the same discussion that we had about naming the amount of PACs.
me? No, it's not. I'm not going to trick you on this one.
PVC.
Say it again.
Couple of PVC.
A couple of PVCs are very close.
Couplets.
This is called a couplet. Okay,
That's what I was talking about whenever we were trying to discuss if there was multiple PACs in the row.
so basically what you're looking at is when you have two PVCs in a row, we're going to call those couplets. Okay.
Is it just two or is it two or more?
No, just two.
Cup.
Just two. Because guess what? If we have three, we're going to call it a triplet.
It's a triple.
It's a triplet, okay? What are we going to call it if we have four? This is a trick question, by the way.
Multiple.
Say it again. No. If we have four or more PVCs in a row, we call it a short run of VTAC. Told you it was a trick question. Okay, short run of VTAC. Because if you look at this,
That's very close to VTAC.
how does the rate compare to the overall? We really can't. We can't come up with a rate because we're not sure if this is a 6-second strip. We definitely don't have any boxes to count. But just eyeballing it, does this look faster than this
Yes.
rhythm, even if we had a normal QRS that occurred over in here? Yeah, absolutely.
It's
Okay.
such an attractive-
So we're seeing those PVCs that are occurring quickly. So again, within here, I would want you to tell me we have sinus, I guess we would call that sinus bradycardia. I mean, normal sinus rhythm if this were a 6-second strip with ventricular triplets that are unifocal. Okay, unifocal. All right. Yes.
The QRS here is not bizarre and wide.
Say it again,
The
now.
QRS is not bizarre and wide.
Oh, I think it is. When you compare it to that QRS, all right, here's where your QRS begins. And basically over here, you'll see this little line here. This is actually where the QRS ends and your T wave begins to form, okay? So if you were to measure this and we had the little dots there, it would definitely be wider than 0.12 seconds. Now, the other thing that we're looking at here, although we don't measure it, is that look at the amplitude of your QRS here, and then consider the overall amplitude, starting right here, of these three QRS complexes. Much taller, although we don't measure it, and much wider. So those are, and we do that, you bring up a good question. We do this in comparison to the underlying rhythms QRS complexes. So we don't compare them to this mental image that we have of what a QRS should look like. We do it, we compare it to the previous QRS complexes. Now let me ask you a question. Landon, get the community laser pointer.
Community laser pointer. That's a thing.
That's the thing.
No.
On the bottom strip, show me where the PVCs are. How do you know? Because the other QRSs look kind of weird to me. Hallelujah. Yep, you're exactly right. You're exactly right. So yeah, so again, we're not sure what lead we're monitoring in here. Simply because your QRS goes down doesn't mean that it's abnormal, okay? That's why we look at the whole complex, the rate, the rhythm, the P wave, the PR interval, and the QRS width. The other thing we know about this QRS, look how narrow it is, okay? Now, and then we look over here at this one, and it's going in the opposite direction. Now, this one, you might be able to make an argument that this may or may not be ventricular. Why would I make that statement?
Can you repeat the question?
No.
It's hard to say if it's ventricular or junctional.
Why? So let me repeat the question. These three in here, you might be able to make an argument that these are not ventricular. Sam, why?
The QRS complexes aren't.
You look at the width of the QRS complexes, okay? We can't really tell because we don't have anything to grade it on and there's no scale there to look at. But again, if it's ventricular, it's got to be wider than 0.12 seconds, okay? So these are triplets, and if we had 4 of them, what did I say we would call it?
Short run VTAC.
Short run of VTAC, okay? So as we're looking at causes, okay, this is a pretty important slide. You might want to keep it, all right? The most common that we've got up in there is myocardial ischemia. We have a decrease in the oxygenation of the ventricular cells, okay? Second thing that come into play here is that we get increased sympathetic tone. Now, that sounds impressive. What does it mean? Increased heart rate, yeah. So we can, when we have an increased sympathetic tone, again, Depending upon whether it's primarily dealing with the atria or the ventricles, remember when we looked at these right here, definitely your heart rate is going to be faster. So it could be there. Again, hypoxia coming in, which leads right back into our ischemia up here. Idiopathic causes. Idiopathic is a billable medical term that goes, I don't know. Okay? I don't have a clue. It may be normal, it may be pathological, but we've done all of our tests and we don't know. Okay? Acid-base disturbances. We'll cover a lot about acid-base when you get into advanced cardiology. Okay? The body likes to be within a very narrow pH range. And when the body gets out of that pH range, things begin to not work well. One of the things that can happen is that we can begin to see things just like this, okay? And then lastly, electrolyte imbalances. I wanted to, not that one either, this one. Okay, so just kind of put it in your back pocket. When you see a T wave like this, there's something going on with potassium. We're not entirely sure just yet whether it's too high or too low. I'm hoping by the time those of you that are taking this class roll into the advanced sequence in the fall. By the way, when we get to the end of class, remind me to make an announcement about entrance exams. We're going to introduce a handheld device that will let you run very limited labs on your patient so that, number one, we could be able to run a lab value and find out if one of the cardiac enzymes, if it's elevated, like troponin level goes up, regardless of what you see on your EKG, that's an indicator your patient's having a heart attack. And then the other thing that we could run is that we could run a potassium level, okay? So that right there by the bedside, you would be able to figure out what's going on with this particular patient. So we've got the device. So hopefully we'll introduce it within your class. But it can become from electrolyte imbalances, and particularly within electrolyte imbalance, we're primarily going to be looking at an imbalance either in the sodium and or the potassium within the heart. Sam, do you have a question or are you just stretching? Okay, no problem. All right. So, as we're looking at this, some of the things that we're going to be concerned about of really looking at our patient is that if we have more than 6 PVCs a minute, okay? So if we have 6 PVCs on a 6-second strip, that gives us cause for concern, all right? R-on-T phenomenon. Who can remind me and tell me what R-on-T phenomenon is?
It's basically when T wave gets too close, the R wave gets too close to the T wave, and it can basically cause the heart to stop.
Yeah. So basically what you will see is the patient will begin having PVCs, and if it looks like it's occurring on the downslope of the T wave, remember that's the relative refractory period. If we get an impulse that hits on that, it puts our patient into ventricular fibrillation. Nice thing about it is, if we got a patient hooked up to a monitor, we lean over, we shock the patient, and almost always it will convert the patient. But it doesn't necessarily mean that he won't go back into that again. So, R-on-T phenomenon. Couplets or runs of ventricular tachycardia, especially when VTach starts and stops, okay? Multifocal, okay? Multifocal PVCs are a concern. And then if you've got a patient sitting that's having PVCs and chest pain, that should raise your little spidey senses, okay? We've got something major that is going on. Yes?
Why is the multifocal more severe than unifocal?
Great question, okay? Who wants to try to answer that for you? Why are multifocal PVCs more concerning than unifocal?
Those come from different sites.
What's that got to do with price of eggs? You're right, but tell me more.
Is the ventricles not controlled as usual?
They come from different sites, so if there was come from the same site, we're confused on
Okay, Sam?
Could it be increasing the risk of RIT phenomenon?
Potentially, but now remember, what did I say was the number one cause of PVCs?
Ischemia?
Ischemia, okay? So if we've got multiple sites, multifocal PVCs, and especially the more shapes we see, the more concerning it is. That tells us we have a larger area of the heart that is probably hypoxic,
That's
okay? So we can get that critical mass of hypoxia within the heart, which leads to a patient having a heart attack and dead tissue. So that's one of the reasons why multifocal would be concerned. And the more shapes you see, the as my friend from Texas would say, the more worser it is.
So is that the same instance as like some of the other like premature contractions that if you fix the hypoxia problem, you could potentially fix
Yeah.
it?
Yeah, and one of the things that you will see with these particular